So Dr. Anna Person completed her medical education at George Washington University. She completed her internal medicine and her fellowship at Duke University. She's been with Vanderbilt since about 2010. She works primarily with the Vanderbilt Comprehensive Care Clinic, where she provides primary care and HIV specialty care for people living with HIV. She is always busy. She does a lot of great stuff here for Vanderbilt, and for us at the AETC, we're thrilled to have her. She's the ID Fellowship Director, and she's also the Clinical Director for the Southeast AIDS Education and Training Center. So thank you so much for taking that on. We appreciate her abilities with us today. Her research interests include transgender care, and she really strives to provide culturally competent, supportive care for transgender individuals, and she really focuses on not just that the medical care piece, but really empowerment and well-being, and she's working with us to provide a support group here in Nashville. So, and she's just one of the calmest, sweetest providers that I've ever met, and we're just thrilled that she's here. So, Dr. Person, I'm going to hand it over to you. And I think that, how is our polling going here? I think that we've got a few seconds left to hear a little bit more about what you do. We've got about 10 seconds left in the poll. So again, how many patients that you see, and how many patients do you provide hormone therapy for, or do you provide hormone therapy? That was the question. So we're going to see kind of how this poll went, and then from there, we're going to start our presentation. You can see our information up there.
Oh, wonderful. So this information is also being shared with everyone who's watching now. Okay, so a number of folks, looks like the majority, well, not quite I guess the majority of folks do see some transgender patients in some setting, and then about 4 folks are personally responsible for providing hormone therapy for their patients. So wonderful. Well, I'll go ahead and get started. Jen, thank you so much for that very kind introduction. I'm always so honored to be able to give this talk. And every time I give this talk, I have to realize that the landscape has shifted dramatically, and it requires a tremendous amount of going back to the literature and updating slides. And I think that represents just how much and how far we've come in this subject area. A little disclaimer that I always give when I give this talk is that I will be talking about hormone therapy, but I'm not an endocrinologist. I'm an infectious disease doctor and an HIV specialist. So the work that I've done in this arena really represents me for the past 5 or 6 years, trying to learn more about the special patient population and trying to do a better job myself of caring for these folks. So these are the objectives of my talk today. As I said, we have a lot of ground to cover, so I'll go ahead and get started. And I really want to open with this picture. So this picture is one of the pictures of Caitlyn Jenner, which perhaps has gotten the most play in social media, in the media, and really has launched this discussion in a social and media arena into outer space. However, I think it's important for us to recognize, although we owe Caitlyn Jenner a great debt for the brave step that she's taken in publicly going through her transition, the reality is that most of our patients won't share a lot in common with Caitlyn Jenner. Certainly don't have the resources that Caitlyn Jenner has, and a lot of our patients are going to share more elements in common with this woman, which is Cricket Nimmons. And I really recommend, for anyone who's interested in this story and learning more about transgender issues, to look at this New York Times profile on this woman, Cricket Nimmons, from New York, who is the first trans woman to take advantage of Medicaid's expansion of services in New York, and is going through and has gone through gender reassignment surgery in New York through Medicaid. So Cricket Nimmons is an HIV positive patient, has gone through a number of challenges in her life that I think will resonate for most of us who care for trans patients. So you will have heard at this point a whole lot in the media about transgender issues. The New York Times has a special focus on it in many of their columns. And of course, there are so many television shows now about trans issues that there was just an article in the Huffington Post, Queer Voices vertical, that asked the question, do we have too many transgender TV shows? So there's a new show on Lifetime called New Girls on the Block. There's a show about a teen or a preteen transitioning on TLC called I Am Jazz. Transparent recently won an Emmy, I believe. And then a few years ago, there was a film called Trans America. Certainly, a lot of you are going to recognize Laverne Cox, transgender actress on Orange is the New Black. But the reason that we're talking about this today is that, well, you may have heard a great deal about transgender issues in the media. Chances are you did not hear very much about this at all in the course of your medical or healthcare provider education. And this is illustrated by this survey, which came out in JAMA, which showed that in the past years, as most of us were going through our training, transgender education was really a wasteland, certainly in medical schools, and I believe in nursing schools as well. So why is this important? There was a survey of 132 deans of medical education. That's 132 medical schools across the country, which is the vast majority of medical schools. And what this survey showed was that the median time during 4 years of medical school dedicated to LGBT-related content was just 5 hours over 4 total years. So 9 medical schools reported that there were 0 hours of LGBT-related content taught during the preclinical years, and 44 schools reported there were 0 hours taught during the clinical years. The extent of most people's LGBT-related education in medical school was that 128 schools taught students to ask patients if they were having sex with men, women, or both when obtaining a sexual history. And I can speak from experience that this is what I was taught and was sort of the extent of my LGBT-related medical education curriculum. Now, our hope is that this is changing. And the reason that this is, I think, a hope that is about to be realized is that this document was released last year, actually now in 2014. This was a 200-page document, which is case-based, which includes cases on HIV risk factors, and is released by the AAMC. It was authored by stakeholders in the LGBT-related community and includes information on curriculum changes for LGBT folks, gender nonconforming, or those born with differences or disorders of sex differences. So I highly recommend looking through this if any of you are educators. It's a tremendous resource for ways that we can start to change medical education to include LGBT-related content. Now, I also recommend that you check out MedEd Portal, which has publications about taking LGBTI inclusive sexual histories, preparing medical students and future physicians for LGBT-related care. And you can see just a number of modules that have been written over the last 1 to 2 years with this express purpose in mind. So now I'm going to step back and take a global view about transgender folks and HIV. And this policy brief was the first of its kind ever published by the World Health Organization in July 2015. And again, I think that this represents tremendous strides globally in recognizing that transgender folks with HIV are a special group that require special attentions. So I'll talk a little bit more about that in a second. First, I want to establish some concepts. These may seem basic, but I think it's important to really pay attention to them. So when we talk about natal sex, that is a sex that a person was assigned at birth. The term transgender is really an umbrella term defined in the WHO document as an umbrella term for people whose internal sense of their gender differs from the sex that they were assigned at birth. And then finally, it is very important to remember that some transgender people do not identify as either male or female, but really identify outside of a gender binary. So the concepts that we're going to be talking about today exist on a continuum. They can be in flux, and I think that's important to keep in mind. Some more concepts is that transgender folks may choose different terms to describe themselves. So some of the terms that are used, a transgender woman is someone who's assigned male at birth, but who identifies as female. And we may say trans woman, male to female individual, or simply female. As someone who is assigned female at birth, but who identifies as a male, can be referred to as a trans man, trans male, female to male individual, or simply male. So the term transition is really important, and that is the process that transgender individuals undergo to express their gender identity. And a definition of this that I just love is the process of bringing the body and mind into alignment. Now, what a lot of folks don't understand, I think is important, is that transition means different things to different people. So for some people, transitioning will include hormones. For some people, transitions will include surgery, but not for all. It certainly includes some degree of social, psychological, linguistic, intellectual, and spiritual changes to the self. So gone are the terms pre-op and post-op, recognizing that surgery may or may not have anything to do with transitioning, and hormone therapy as well. Some more basic concepts, and I encourage you to really think about these and sit with them for a second. They may sound simple, but I think they're really important to take to heart. So the first concept, and this is something that I try to stress with my trainees and my learners when I'm teaching, is that biologic gender may differ from gender identity. Gender identity itself can be distinct from sexual orientation, and sexual behaviors may differ from sexual orientation. So someone may identify as straight, but they may have had a same-sex sexual experience. And keep in mind that gender identity, as I mentioned, can change. It's fluid. So nothing here is static. Now, I want to talk a little bit about gender dysphoria. And this is a term that you will probably have heard because this is the term used in the DSM-5 manual, which is the manual for the American Psychiatry Association. And this gender dysphoria term replaced the previous term in the DSM-4 of gender identity disorder. And for the first time, and this came about in May of 2013, gender dysphoria had its own chapter, and it was separated from its previous home in the sexual dysfunctions and paraphilic disorders chapter. So finally, we're seeing some progress in the medical literature as well, recognizing that this sense of gender dysphoria is not a disorder, but rather is defined as a sense of someone whose gender at birth is contrary to the one that they identify with. And the definition in the DSM-5 is that there must be a marked difference between the individual's expressed gender and the gender that others might assign him or her that should continue for at least 6 months. There is a separate definition for children, and this condition, this gender dysphoria, causes significant distress or impairment in functioning. And this is a term that you'll come across when providing care in a medical setting to transgender individuals. So let's talk a little bit about how many individuals identify as transgender. And this is really difficult to know. One, because as we talked about, definitions of gender identity are fluid. Two, stigma is huge. So often people are not coming forward and identifying themselves as transgender. And therefore, these numbers probably are a vast underrepresentation of how many people would self-identify as transgender out there in the world. Now, most of the data on numbers of how many folks identify as transgender come from the Netherlands. And the reason that that happens is that in the Netherlands, sexual reassignment surgery is covered by the government completely. And so these numbers represent people who are presenting for surgery. But as I mentioned, not all trans folks are going to want surgery. So again, this is probably an underrepresentation. At least in the Netherlands, one of about 12,000 men and one in about 30,000 women identify as transgender. And importantly, for about 2/3 of these individuals, this feeling of gender dysphoria, that they're in the wrong body than the sex they were assigned at birth, begins very young in childhood. So let's look at transgender issues with HIV globally. Again, a lot of this comes from the WHO policy brief, which was published in 2015. First of all, there are not much data on HIV trans folk out there in the world. Prevalence data are less robust because of sampling challenges, lack of population size estimates, and of course, stigma. You can imagine trans people who are HIV positive in Bangladesh or Pakistan or India may feel even less empowered to come forward and self-identify as transgender, and thus we are probably underrepresenting our numbers globally when we're talking about trans individuals. We know transgender individuals with HIV are severely underserved, and only 39% of countries reporting in the National Commitment and Policy Instrument in 2014 said that their national AIDS strategies specifically address transgender individuals. How many transgender individuals in the world have HIV? In meta-analyses on the subject, there is a pooled HIV prevalence of nearly 20% of trans women across 15 countries. So 1 in 5 trans women globally is estimated to be HIV positive. Importantly, trans women had nearly a 50 times greater risk of HIV infection than the general population. And if you look at trans women who are sex workers, there was a pooled HIV prevalence of 27%, or nearly a third, versus 15% of trans women who are not sex workers. Now, interestingly, if you look at trans men, or female to males globally, there is even less data. So the only published studies on HIV prevalence among trans men are from North America, certainly not representing the rest of the world. And the recently published meta-analysis found only 2 studies with laboratory-confirmed HIV status data among trans men. One of these studies found no infections among participants, and the other found 1 HIV-positive participant. So for the most part, when we're talking about HIV infection in the transgender community, we are talking about trans women. So let's look locally. When we're talking about local trans individuals and trans women with HIV infection, the data suggests that somewhere between 11 to 28% of trans women are HIV positive. This is a huge number. If you can think that somewhere between a fourth, almost to a third of our trans women are going to be our patients with HIV infection. And in fact, in 2010, CDC data suggested that the highest percentage of newly positive HIV test results were in African American trans women. Now, for trans individuals, more than half of the testing events occurred in non-clinical settings, which I think is an important clue for those of us who are interested in testing about how we can reach this unique patient population. And then also, there was a 3 times higher community viral load in trans individuals compared to non-trans individuals. So what are some of the challenges that our trans HIV infected patients are undergoing? Well, we know that based on one study in New York at least, trans women in New York City newly diagnosed with HIV infection, fully half, reported a history of substance use, sex work, homelessness, incarceration, or sexual abuse, versus 31% of HIV positive women who are not transgender. If you look at trans women who are sex workers, and many of the folks at our clinic do have a history of sex work, we know that there are extremely high rates of depression and discrimination. This study of 573 trans women sex workers showed that African American trans women were most likely to report transphobia. Half reported a history of physical assault at some point in their life. This is very important to think about when we're talking to our patients in the exam room, taking a history and physical. And nearly 40% reported a history of rape or sexual assault before the age of 18. So in an effort to learn more about the health status of transgender individuals, the CDC is revising the national system for reporting HIV cases to capture sex assigned at birth and current gender identity. So hopefully we will have more information about this medically fragile and vulnerable population so that we can address some of our efforts towards this group. Again, in a sign of the times, updated in July 2015, the White House released its national HIV/AIDS strategy for the U.S., which for the first time was revised and updated to 2020. And goal number one of this strategy was to reduce new HIV infections in particularly vulnerable groups. And you can see people in the southern United States, where we all live and reside, is listed here, and of course trans women, noting the particularly high burden of HIV among Black trans women. So this certainly has the attention of the White House, and now a national goal for healthcare providers everywhere. So now I'm going to talk about healthcare maintenance and basic healthcare for our trans patients as we're caring for them in the exam room, in clinic, day in and day out. Now, these are guidelines that are specifically developed for HIV, people living with HIV who are trans, developed by New York State Department of Health in conjunction with Johns Hopkins University. I do want to point out that there is also another primary care protocol for transgender patient care, which can be found at transhealth.ucsf.edu, and this is an extensive document and a really valuable resource, which covers everything from diabetes to gynecologic health to screening for depression in transgender folks with and without HIV. So I encourage you all to look at this resource as well. So when we look at the New York State and Johns Hopkins guidelines on caring for HIV, for people living with HIV who are trans, one of the first steps that they recommend is a psychosocial assessment. So what does this entail? Well, in reality, this is what we do every day, all day with our patients. To spell it out, they recommend that as a part of routine management, clinicians should perform a psychosocial assessment baseline and annually in HIV-infected transgender patients. What should that consist of? Again, I think most of us intuitively do this, but it's really important, as I mentioned, to pay attention to certain aspects of the psychosocial assessment or taking a history and physical. So it's really important to talk about a support network. There are incredible rates of depression, violence, sexual abuse, and stigma in this community. So assess for social support, assess for stability in relationships. Ask about violence and discrimination, because I can guarantee you that other folks aren't asking. So this is our window of time to really get to know our patients and their unique challenges, and to reach out and ask about stigma, violence, discrimination, sexual abuse. Ask about housing. We know that homelessness affects our trans community at a particularly disproportionate level. Ask about what it's like for them at work. Ask about educational level and legal issues. These are all things that we can take the time to inquire about. An important aspect here is harm reduction. And this is included in the New York State guidelines and the Johns Hopkins guidelines, which is that we should really assess for the following behaviors for our patients. Silicone use, which I'll talk a little bit more about later, we need to ask the question about whether or not people are using silicone, which they could be buying on the street, which can cause tremendous harm and tremendous risk to our patients. Hormones obtained without a prescription, including names and types of specific hormones used, which could cause risk, and I'll talk about that. Needle sharing, again, could be at increased risk for hepatitis C. Sexual risk behaviors, and genital taping, which actually can do a tremendous amount of damage, and I have seen this in my own patients with tucking and genital taping. When we talk about the physical exam, I think it's important to understand that just the simple act of doing a physical exam on our patients can be extremely traumatic. I have one patient in particular, it took me about a year before I could do a complete physical exam on her. We had to spend hours building trust, building relationship before she felt comfortable with me examining her. Explain each step of the exam. If you're doing a gynecologic exam, use the smallest possible speculum. Consider referral to our psychiatric colleagues. And if you have to, defer the exam if the patient is not comfortable. Every effort should be made to provide the appropriate care for these patients and make sure your patient understands the risks of deferring certain steps of the physical exam. But the bottom line is building a trusting relationship with our patients is going to, in the long term, benefit them most. Let's talk a little bit about pap smears. I get this question a lot. When are pap smears indicated? So according to the guidelines, clinicians should perform routine cervical pap tests in any HIV-infected female to male patient who still has cervical tissue. Keep in mind, if your female to male patient who still has cervical tissue is on testosterone, that testosterone-related atrophy of the cervix may mimic cervical dysplasia, and you should let your lab know. PAP is not necessary for male to female patients who've undergone surgery. Breast cancer screening in and of itself is controversial, and I'm going to stay away from that part of it. But if you look at the guidelines, which were recently reviewed again and updated, mammograms are recommended according to the established guidelines, which again depends on which guidelines you're looking at, for those for natal females. So a female to male with any residual breast tissue should undergo mammograms according to established guidelines. And then importantly for me, female to male patients in your clinic with breast tissue who've had hormone therapy for 5 years or more should be getting mammograms. That was an important teaching point for me. Male to females on hormone therapy are at likely a higher risk for breast cancer than those born male who are not on hormone therapy. So I am going to switch gears here and talk about the specifics of hormone therapy because this does, in our clinic, comprise a lot of our basic health care and requires a certain amount of knowledge about endocrine issues and monitoring for hormone therapy. And I am going to talk briefly about this just so that you're familiar with the issues. So the goals of the treatment should be to safely reduce endogenous sex hormones and then to safely administer exogenous cross-gender or cross-sex hormones. This table here from a really good review from 2009 from the Endocrine Society just outlines the timeline of effects of exogenous hormones, where you can see, because some of your patients, when you're starting hormone therapy, they're going to want to know at what point do I develop breasts? At what point do I have decreased libido? At what point do I have redistribution of body fat? There's an onset time period, and then there's maximum changes can be expected, sometimes in 2 to 3 years. So breast growth will start between 3 to 6 months, but it won't reach its maximum till 2 to 3 years, and it's important to discuss timeline and expectations with your patients. This woman on the right is Jenna Telakova, who is the first ever transgender Miss Universe pageant contestant back in 2012. So it's important to point out that to date, no controlled clinical trials of any feminizing or masculinizing hormone therapy has been conducted to evaluate safety or efficacy. So we don't have clinical trial data on hormone therapy, and frankly, we probably won't. But we do have some data out there. So in a meta-analysis of 28 studies of individuals on hormone therapy for cross-sex purposes, looking at about 1,000 trans women, about 800 trans men, hormone therapy really works for our patients. 80% of individuals, once they started hormone therapy, reported significant improvement in gender dysphoria. Nearly 80% reported improvement in psychologic symptoms. 80% reported significant improvement in quality of life, and 72% reported improvement in sexual dysfunction. So if you could think about an intervention that we can do for our patients that would bring such significant levels of improved sense of well-being, I think most of us would find these numbers very convincing, and for our patients, hormone therapy is often indicated. Now, what guidelines do we use when picking hormone therapy for our patients? There are a number of different guidelines about which hormones to use. I've listed a few of them here. So the gold standard of care for trans patients is really considered this document here, the World Professional Association for Transgender Health, or the WPATH. This was last updated in 2012, but is reviewed frequently. And it was previously called the Harry Benjamin International Gender Dysphoria Association. Now, there are another of other documents that I would refer you to. The Endocrine Society issued clinical practice guidelines in 2009. There's a wonderful New England Journal of Medicine review in 2011. And then two of the most famous clinics, the Tom Waddell Clinic and the Fenway Clinic, which is in Boston, have published their protocols on treating trans patients. So I really recommend that you look at these protocols if you yourself are going to start providing hormone therapy to your patients. Now, these are some of the summaries of the different protocols. You can see that all recommend an initial diagnosis or mental health evaluation before starting hormone therapy. Reproductive counseling is something that you have to keep in mind, especially with your younger patients. Starting hormone therapy will have profound and in some cases irreversible implications for reproductive futures for our patients. And these are spelled out in the WPATH guidelines and specifically for adolescents in the Endocrine Society guidelines. This should also be included in your consent. And then mental health requirement for those with concomitant mental health challenges such as depression, bipolar disorder, schizophrenia are thought to be recommended throughout transition, but not necessarily a requirement. So when can we start hormone therapy for our patients? According to the gold standard document, the WPATH guidelines, you can start hormone therapy for your individual patient after a psychosocial assessment, usually by a mental health professional, and after informed consent is obtained. The criteria all state that it's important to live for a year in the desired gender role prior to initiation of hormone therapy. I think this is a really interesting requirement. And the reason that it is problematic is I have had some patients come to me and say, you know, you can't order heels in size 13. And so what exactly does it mean to live for a year in the desired gender role? Does that mean dressing as a female? Does that mean being referred to as a female by a female name in social settings? So there really is a lot of room for interpretation in this criteria of living for a year in the desired gender role. Another thing that I've had a patient say to me is that it's incredibly expensive to buy a whole new wardrobe of clothes and makeup, etc. And so I think we have to be cognizant that living for a year in the desired gender role is going to differ from individual to individual. Criteria should be persistent gender dysphoria. There's that term again. You have to be able to make an informed decision and to sign the informed consent. You have to be of the age of majority in a given country, whatever that may be. And then if there are significant medical or mental health concerns, they must be reasonably well controlled. Now that's come up for me in the past too. Say someone has advanced AIDS and aren't taking their antiretroviral therapy. Does that mean that now is the time to start a hormone therapy transition? And again, I think all of that is up for debate. What does informed consent need to consist of? There are documents of the informed consent template that you can choose for your clinic. Callan Lord Community Health Center in New York City has an excellent document, as does Fenway Community Health and Tom Waddell Clinic that you can use as for your clinic. But basically the gist of the document needs to say that hormone therapy will lead to irreversible physical changes. You have to document that risks and benefits have been explained, including the impact on reproductive capacity. Your patient may not want children at that moment in time that they initiate hormone therapy, but you have to keep in mind that they may change their mind in the future. So specifically, if we talk about hormone therapy for trans men, female to males, what does that entail? Well, the gist of it is that it entails testosterone. Testosterone supplementation or exogenous administration will cause increased muscle mass, decreased fat mass, Facial hair acne can cause male pattern baldness and increased libido. It will cause cleromegaly, decreased either temporary or permanent fertility, again, very important to discuss, deepening of the voice, and cessation of menses. Feminizing therapy for trans women or male to females includes estrogen and in some cases androgen blockade, which I'll talk about. You're going to have a change in body fat redistribution, decreased muscle mass, enlarged breast, decreased libido and spontaneous erections. And that's important to talk about with your patients. What does sexual activity consist for that individual? And if it does consist of erections, you need to let your patient know that once starting feminizing therapy, those will go away. Decreased sperm production, again, implications for reproduction, thinning of body and facial hair. And then two very important caveats to talk about is that estrogen therapy or feminizing hormones will not affect the pitch of one's voice. And that once an individual develops breast from feminizing hormone therapy, breast size is generally not reversible even after you stop hormone therapy. So again, what is the timeline here? If you look at the Endocrine Society guidelines, you can see that there's a timeline for each and every one of these physical transformational aspects that your patient needs to be aware of. Again, breast growth may take 2 to 3 years of hormone therapy before it reaches its maximal amount of change. Specifics on hormone therapy for trans men, which is testosterone. These are the most commonly used doses and protocols here. And you can see different protocols there, the Endocrine Society and then the Tom Waddell protocol. Male to female hormone therapy, however, or feminizing therapy for trans women is more complicated. Often it consists of estrogen plus an anti-androgen therapy or androgen blockade. So the anti-androgens, the goal is to reduce circulating endogenous testosterone levels down to levels found in biologic females, and then you supplement with estrogen. Examples of anti-estrogens include Prolactin or finasteride, GnRH agonists like Lupron, which is an injection, or often bilateral orchiectomy. Now, anti-androgen therapy is then supplemented with estrogen therapy. It's important to ask about non-prescription use. So are your patients buying estrogen from sources that are not you? You have to explain that response to estrogens are variable. And then some general pearls is that because of risk for venous thromboembolism, which I'll talk about, it's important to stop estrogen therapy before a major surgery and resume it a week after. There are risks for embolic events, so you want to consider adding aspirin for those who smoke, who are greater than 40, those who are obese or have cardiac risk factors. I'll talk more about that in a second. Specific estrogen protocols, as you can see here, are 2 different protocols, and I really like the Tom Waddell protocol because they give starting, typical, and maximal doses. It's the estradiol valerate or del-estrogen that we use here at our clinic, and those doses are titratable. Now this is a tiny little table, and I'm not showing this to you so that you read every little word on here, but the point of this slide is that this is the Endocrine Society's recommendations on what we need to do for monitoring once your patient is started on cross-sex hormones. And what this entails essentially is intense monitoring of laboratory markers with DEXA scans, CBCs, LFTs, and I think the point here is that you can't start patients on hormone therapy and then do nothing else except for continue their hormone therapy. This really is a complex system and requires intense monitoring to make sure that you're doing no harm and that you're achieving maximal results. This is the monitoring for male to female individuals on cross-sex hormones. So a word of caution, when giving estrogen therapy to our trans women, you have to think about prolactin. So estrogen therapy increases growth of pituitary lactotroph cells, and in fact 20% or 1 in 5 of trans women who receive estrogen may have elevations in prolactin. Usually decreasing the estrogen alone can normalize the prolactin, and you have to monitor it at baseline and twice a year. Some psychotropic medications like benzos, Buspar, MAOIs, SSRIs, TCAs, Haldol, Imitrex, Depakote, a lot of these medications that our patients are going to be on can also increase prolactin levels, but you have to be worried about prolactinomas. Overall, the risk of prolactinoma is thought to be rare, but your patient will not always have other symptoms. If the patient has a persistently high prolactin level that's not going down, you will need to MRI the brain to rule out a prolactinoma. So there is potential to do harm while giving hormone therapy for cross-sex purposes. Now here's a question that I commonly get, which is, how do HIV medications interact with hormone therapy? And the answer is, we really don't know. We don't have a lot of data. This is the section on drug-drug interactions from the DHHS guidelines, and it's the hormone contraceptive section. So most of our data has to be extrapolated from the hormone contraceptive drug-drug interaction table. So we know that in general, most protease inhibitors decrease estrogen levels. Therefore, if estrogens are continued, but your protease inhibitors are abruptly stopped, you have to keep in mind that this could lead to a sudden increase in estrogen level in your patient's bloodstream, which has been associated with adverse events such as stroke, pulmonary embolus, or DVT. So keep in mind specifically for your patients on protease inhibitors and estrogens that a sudden stoppage of their protease inhibitor could lead to a rebound or a dramatic increase in estrogen level and possibly adverse events. How safe is hormone therapy? Again, as I mentioned, there's no clinical trial data, but we do know in a study, again out of the Netherlands, that of patients followed for about 18 years on hormone therapy, there was a higher mortality group, a 51% higher mortality in the trans women, but unfortunately, almost all of that higher mortality was due to suicide, HIV or AIDS, cardiovascular disease, or drug abuse. There was no increase in total cancer mortality for the most part. However, ethinyl estradiol, which is most commonly found in oral contraceptives and therefore might be something that your patient is buying on the street, is associated with a 3 times higher rate of cardiovascular death. So when you're asking your patient about hormone therapy, ask them about ethinyl estradiol use. For the female to male or trans men, there was no difference in mortality compared to the general population. As I mentioned, the oral contraceptives are associated with increased risk for venous thromboembolic disorders. Now, if you are worried about blood clots for your patients, the risk is highest with oral estrogen supplementation and lowest with transdermal. Age and smoking status increase risk, which begs the question, if you have a patient who smokes 2 packs a day, has already had 2 heart attacks, how comfortable are we giving estrogen therapy? On the other hand, you don't want to deprive someone of something that's so important to their well-being. For those who get both androgen blockade and estrogen therapy, we can induce in our patients a syndrome that looks a lot like the metabolic syndrome. So masculinizing therapy or testosterone for our trans men causes preservation of bone mass. Interestingly, spatial abilities improve, but verbal fluency is found to be diminished in those who get testosterone therapy. I'm not going to make any comments about that, although it's so tempting. I am going to talk briefly about surgery, so gender reassignment surgery, or sometimes called sexual reassignment surgery. Keep in mind that this is, for the most part, out of reach for the majority of our patients due to cost. Now, if you look at the WPATH guidelines, there are guidelines about when someone can qualify for gender reassignment surgery. And the guidelines state that the patient must have lived continuously in the gender role for 12 months. Chest surgery for female to males, which is bilateral mastectomy, can be done earlier. Important to note, after surgery, your patients will have to continue hormone therapy, and this is not going to mean that they are never going to have to be on hormone therapy again. Now, again, in the WPATH guidelines, surgery, referral for surgery requires support from us. And you may be approached to write a letter from one of your patients. So there is one letter required from a mental health professional saying someone qualifies for gender reassignment surgery, an additional referral for breast or chest surgery, which is a mastectomy. 2 letters are required for those who need hysterectomy, orchiectomy, or genital reconstructive surgeries. The criteria for what needs to be said in the letter is laid out in the WPATH guidelines explicitly if you are ever called on to write a letter. Now, the vast majority of our patients cannot afford surgery. It usually costs over $300,000. In some cases, again, in the Netherlands, it's totally covered. Here, there are some, Medicare is now covering gender reassignment surgery, and 9 states have lifted the requirement or have now started covering Medicaid costs for gender reassignment surgery. So this is an example of the male to female sexual reassignment surgery, which includes penectomy, orchiectomy, construction of a neovagina, which can be done with skin from the scrotum or from the colon, and is a complex surgery. The female to male surgery, however, is infinitely more complex, and sometimes this can cost up to $100,000. It is usually a multi-stage surgery with really high rates of morbidity and mortality. I should say morbidity at least. Requires a hysterectomy, mastectomy, and then creation of a phallus, a vaginectomy, and a scrotoplasty. The phalloplasty is often done with a vascularized free flap, and it's a lengthy multi-stage procedure which can include urinary complications. And for that reason, many male to females just choose to undergo a hysterectomy, oophorectomy, and or mastectomy. Now, in terms of sexual reassignment surgery, what do we know about patients who undergo sexual reassignment surgery? Again, data from the Netherlands say that most studies show that it really improves this feeling of gender dysphoria. One question that comes up is how many folks regret going through such a difficult surgery. Data from the Netherlands suggests that that's just 1% to 2%, and most of those are those with so-called late transsexualism. Again, I'll point out that that's not a term that we would use that much anymore, but this is the wording used in the article. In a cohort studied in Sweden, followed about 300 patients who underwent sexual reassignment surgery and matched them with individuals who did not undergo sexual reassignment surgery. They showed that there was an increased risk of death from suicide and overall mortality for those who underwent sexual reassignment surgery. So the authors of this study conclude that sexual reassignment, although alleviates gender dysphoria, really should not be considered a standalone treatment for, again, what they call transsexualism, but should inspire improved psychiatric and holistic care after surgery. So even though folks who do achieve sometimes a lifelong dream, again, not for everyone, of having gender reassignment surgery, the challenges that remained before and sometimes are inherent in the lives of trans folk are not alleviated by undergoing this surgery. So importantly, Medicare, as of May 2014, will now cover sexual reassignment surgery. Interestingly, it doesn't cover hormone therapy, so that's a problem in and of itself. And then 9 state Medicaid programs, as I mentioned, will cover transgender-related health care to some extent. New York is now covering gender reassignment surgery in Medicaid, as I mentioned at the beginning of the talk. However, as far as we know, there are really no more than 10 surgeons nationwide who perform vaginoplasties and fewer than 6 will do both male to female and female to male genital surgery. We don't really have anyone in Tennessee that we refer to who does sexual reassignment or gender reassignment surgery. We have some folks who will do mastectomies and orchiectomies, but the vaginoplasties, really there's an extremely small group nationwide of people who are qualified to do these complex surgeries. So a final few notes about improving care. These are simple, small things that we can do to improve the care of our trans patients. Please, I beg you, use your patient's preferred name and pronoun. And if there's a question about what that is, just ask. Nothing makes me cringe more than hearing a patient being called in the waiting room by their given name but not their preferred name. And I think we have a long way to go with medical records in terms of improving and capturing patients' preferred names and gender in the EMR. Utilize the same language the patient uses when talking about their life. So use the term partner, significant other, until you know more about them and their story. Acknowledge transition challenges. This transition is a journey and has a number of challenges associated with it that most of us can never even imagine. Loss of family, community, friends, the feeling of passing or getting clocked or called out, dating issues, that comes up in our support group as the most desired topic of conversation, which is how does one date while trans? Safety issues, again, if you don't ask about it, no one else is. And self-esteem and confidence. Please don't make assumptions about sexual activity or preference based on someone's appearance. Remember that behavior may differ from professed sexual orientation. Question about specific sexual practices and behaviors are much more important than about sexual orientation. Do ask about silicone and harm reduction. I do have patients who have had tremendous complications from the use of black market silicone. Risk of silicone emboli or silicone syndrome can cause ARDS, fever, dyspnea, hemoptysis, disseminated Staph aureus infections, and can be fatal. So a simple thing for harm reduction would be to ask patients, have they ever used silicone? And if so, how are they doing it? When was their last use? So in conclusion, gender identity is separate from biologic gender. That is a very simple but revolutionary statement that I hope that we can all come to embrace and teach to our learners. Physical exams may be traumatic for our patient, but appropriate healthcare maintenance should be the goal. Hormone therapy has risks and benefits. Informed consent is a must, and risk reduction and harm reduction is important. And finally, we can always strive to do better and provide compassionate care. Thank you so much.
Thank you very much. Appreciate it. Thank you, Dr. Person. We had a couple of questions come in through the chat box, and someone wanted to know a little more information about tucking and taping. Could you talk about that a little bit more?
Yeah, so that's really important. So for in our male to female patients, in my experience, the vast majority of them will tuck or tape, which means that they're taking their penis and scrotum, pulling it back, and then taping it, usually on the underside of their perineum, almost into their gluteal cleft. And I actually have had a number of patients with long-standing testicular and scrotal pain who have had marked abnormalities on abdominal pelvic CTs with hyperemia in their inguinal canal. I'll get calls from radiologists who won't know that the patient is trans, won't know that the patient has been tucking, and describe these abnormal findings. So, I don't think there's a lot we can do except ask if it's happening, and then to talk about some of the pain and damage that can be done during that time. You can have long-term damage to the spermatic cord, and really I think it's just something that we need to ask about to see if it's happening for our patients.
All right, and you can see the Q&A there. There's a question from Catherine about those that can't pass. Would you mind answering that?
Yeah, for those who can't pass, it may be unsafe to live publicly before beginning hormone therapy. Oh, that's really hard. So that's why I think that criteria of living for a year in the desired gender role is very challenging. And really, it's up to the person who is initiating hormone therapy to decide if people meet that criteria or not. Not to mention, as I discussed, it's incredibly expensive to all of a sudden dress and look in a different gender. So I think what you have to do at the very most is just address safety at all times. You know, I talked to one of my patients who was a manager at a retail store who was very young and trying to decide, you know, literally, do I just show up one day looking and dressed as a woman when, you know, for the last several months everyone has known me and to be dressed as a man. So I think safety is first, and we're just going to have to pay attention to the fact that not everyone can meet the letter of the law in terms of living for a year in the desired gender role. And yes, I think Jen, we can provide this resource for trainers for the medical students for sure.
That's no problem. And we have a couple more that have come
Sure.
into the chat box.
How are folks dealing with issues where the client comes in stating their name is X, for example, but their legal name is dissimilar, in particular for someone coming in for HIV testing and data collection purposes?
Yeah. So should I repeat the question? Yeah. The question is, how do you deal with the issue when someone comes in asking to be referred to a name X when their legal name and legal gender is something different for data collection purposes? I can only hope, and I've been giving this talk for 5 years now, that the CDC, and some of you may know this better than I, who are at the front lines of collecting data, that the CDC will continue to work on their end about recording not just sex assigned at birth, but current gender identity. Not just the CDC nationally in their national HIV/AIDS surveillance data, but all data collection. I can tell you from our standpoint, our EMR only captures legal name. So I make an effort to put a pop-up on the chart for all of my patients that prefer to be called a different name, so that when they are called from our waiting room, they're called by the appropriate name.
Great. There are a couple more coming in there. So Daniel asks, can you talk about any future suggestions about risks around body? Okay, you did kind of mention that.
Frank's other guidelines for hormone therapy
for youth. Yeah. So there are if you look at the WPATH guidelines, I think that you'll find them there. This is a tremendously difficult issue. So most folks feel that for children who have gender dysphoria, that it is important to begin hormones for transition prior to puberty, so that one does not have to go through puberty in a gender that one does not feel is their true gender. Now, there are not many people who provide hormone therapy for youth for cross-sex purposes. We are lucky at Vanderbilt to have a doctor who does do that. But that is a controversial area, and the thought about when to start hormone therapy in children and adolescents is one that continues to be debated. When the transgender person is admitted to a hospital, what's the best way to manage bed control, single rooms? Yeah, so this has also come up for a patient of mine who recently went to college, and there was an issue about dorm assignment. I would hope that those who are in the administration section of making these decisions will have an understanding view of the situation, and sometimes that requires, I think, advocacy from our part. But yeah, I think a single room would be appropriate. In my patient's case, it was something that we had to work very closely with the administration of the college about. Is there a list of healthcare providers who will prescribe hormones in Tennessee or southeastern U.S.? I really think that we can work on developing that list. There is a list that we have here in Nashville of folks who provide hormones for cross-sex purposes, the issue that comes up in our clinic at the CCC is insurance. So we end up, this is kind of why I got into this to begin with, is we end up doing hormone therapy for our patients with Ryan White or without traditional insurance because they can't be referred to an endocrinologist. But we can work on collating a list like that. I think that's an excellent idea. Thank you, Catherine. Heather asks, are there guidelines in place for using hormone therapy that are smokers? No, there's not. So all that it says is that you should consider that they're going to have increased risk for venous thromboembolism and consider adding low-dose aspirin. I think that it needs to be addressed in the informed consent, and I personally type it every time I see a patient in my clinic note. I say smoking cessation was encouraged. We discussed excess risk for venous thromboembolism and other adverse events like cardiovascular disease. And then I make sure that we know that the transdermal forms of estrogen are the lowest risk for those who are smokers. I've gotten the question before, do you withhold hormone therapy for your patients who are smokers and at high risk? And I personally do not feel comfortable withholding something that is so crucial to someone's identity and well-being. And I don't want to use hormone therapy as a stick for my patients, and that's my personal feeling. Have you or anyone in your clinic come into a male to female who developed breast cancer? No, I have not. I will say that talking to patients about mammograms has been an interesting experience to explain what they are, to explain why they're necessary, but we have not seen anyone develop breast cancer early in the stages of hormone therapy. Now we know that if they do develop breast cancer and they have an ER, PR, an estrogen receptor or progesterone receptor positive tumor, that's going to get complicated real fast because exogenous estrogen at that point could potentially be dangerous. Oh, sorry.
The chat box moved really quickly,
I'm so sorry.
That's why that one.
Talk a little bit about sexual function after transition. Well, so the data that we have suggests that sexual function improves after the initiation of hormone therapy. And that's why it's important to ask your patient about what sex entails for them, because sex is going to mean different things for all kinds of different people. And if suddenly someone's going to stop getting an erection, I think that's going to have to be brought up before you start hormone therapy. Now, sexual function after sexual or gender reassignment surgery is a whole different thing. And not a lot is known about that. For those with vaginoplasties, those are functioning vaginas in that one should theoretically be able to have penetrative intercourse. The phalloplasties often don't function. In other words, they don't often get erections. Sometimes you can implant a device that you can pump up to get erections for phalloplasties, but those typically aren't as much functional as they are for physical appearance. Is there a toolkit that's been developed to train ancillary staff on best practices? I would refer you to the AAMC document, which was published in 2014, which is the best and most comprehensive thing I've seen to date. And one of the lead authors on that was Dr. Kirsten Ekstrand, who led our transgender program here and started the Trans Buddy program here at Vanderbilt, and she is a national leader in the field. Equality Florida has a trans resource guide available. Oh, wonderful. We'll have to look at that.
Everyone, thank you so much for tuning in. Dr. Person, thank you very much for your time. I know we've gone a little over this morning, but the information was really worth it. And tune in next week for Webcast Wednesday. We will see you again. And thank you, everyone. Have a great day.